It's Dr. Sabrina Siegel here with a special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy Show. In this series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. The next theme is on how to effectively manage complex treatment-resistant psychotic disorders. In this theme, we will discuss several books: Treatment-Resistant Psychotic Disorders by Dr. Michael Cummings and Dr. Stephen Stahl, the Clozapine Handbook by Dr. Jonathan Meyer and Dr. Stephen Stahl, and The Clinical Use of Antipsychotic Plasma Levels by Dr. Jonathan Meyer and Dr. Stephen Stahl. Today, Dr. Andy Cutler interviews Dr. Jonathan Meyer on the use of clozapine in clinical practice. Let's listen in to part 2 of our theme, the Clozapine Handbook.
Hello and welcome to another episode of the PsychopharmaStahlogy Show, our podcast with Dr. Stephen Stahl. And today, we're doing the first of a 2-part series with Dr. Jonathan Meyer, a good friend of mine and really one of the world's authorities on psychopharmacology. And today we're going to be talking about the Clozapine Handbook that Dr. Meyer published with Dr. Stahl. I'm Dr. Andy Cutler, Chief Medical Officer of NEI. I'd like to welcome Jonathan.
Hey, Andy, how are you doing? Thank you for having me.
And I'm on board for color
Steve.
Commentary.
Exactly.
This is Steve Stahl. Andy will lead the pack, and I'll chime in when I can.
Absolutely. Jonathan, I'm kind of curious. I've been joking with you that you're sort of the king of the underutilized medications now. What was the impetus to write the Clozapine Handbook?
Well, I think you just said it in a nutshell. Clozapine is the only medication that works for treatment-resistant schizophrenia. We'd say at the minimum, 40% of people who really are treatment-resistant will respond to clozapine, but it's underutilized, and the big reason it's underutilized is due to the adverse effects. People are afraid of the adverse effects. They don't know how to manage the adverse effects, and that's been a big impediment to more widespread use, despite the fact that there really aren't therapeutic options.
Yeah. So is it fair to say people are actually afraid of this medicine?
They really are, and it's unfortunate. And I think it's not a fear because they have an inherent fear of the molecule clozapine, but they know, people can get severe neutropenia. They know that sometimes people get ileus. And because they don't understand perhaps how to manage those, I think it's just a fear born of lack of education. And to the point that education really does improve people's sense of accomplishment and reduce their anxiety, almost as effective as a benzodiazepine. At the state hospital where I've been with Dr. Stahl for a dozen years, we've been doing a series of lectures on how to use clozapine, and we've more than doubled use. Am I right, Steve? More than doubled use.
That's right. Well, the thing that's interesting, Jonathan put his finger on it, and we all need to take our hat off to the service that he's doing, because there's no marketing of drugs that are generic, even if they're the best in class. And so what he's done is created a vehicle for confidence. Now, if you're going to prescribe, you have to know, if you run into trouble, what do I do? And I can be confident to handle it. And so it's no other source of information better to gain that confidence than this book. And so you can prescribe because you know what to do if there is a problem.
Yeah, Steve, I really have to agree. Jonathan, I think you have done the field quite a service here. This is a medicine that when it first came out, I was actually in my residency, and I remember the excitement around this medication. Steve, we were really excited about this medicine. What happened?
I think neutropenia happened. I think, patients had side effects, and, doctors are afraid of it. And the other thing that happened is it wasn't marketed. So there was no big pharma behind it. And, newer drugs were coming out, getting all the bandwidth from everybody. And I think it diverted us from using it. What do you think?
Yeah, you're absolutely right. I mean, I think about the fact that if I hold up the clozapine molecule and I put quetiapine and olanzapine next to it, you'd be hard-pressed to tell the difference. People were trying to say, we've got something as good as clozapine here, but it's safer and easier to use. And so there was probably some hype there. And then there's the pain in the butt factor, let's face it.
It wasn't true.
No, definitely not. And then there's the pain in the butt factor, Jonathan. I mean, the fact that you have to sort of have resources if you're going to be using this medicine. What do you think about that? Just the practicalities of it.
Yeah, the hematologic monitoring has always been an issue. I think, to be honest, there's a lot of people questioning whether there is even a need for what's called the REMS program anymore in the U.S., which is a risk mitigation strategy imposed by the FDA on certain types of molecules. You know, maybe when Clozapine came out over 33 years ago, a third of a century ago, perhaps psychiatric professionals couldn't be trusted to look at an ANC. God forbid we look at a CBC and try to interpret it. But I think nowadays everybody knows what they're dealing with. The monitoring protocol is well established. We now have an adjustment for people who have benign neutropenia. It's already there. And I think there are people who are trying real hard to say the need for the REMS is not there anymore, mostly so that we can perhaps scrap some of the onerous monitoring, especially when people have been on it more than a year. As you know, the neutropenia risk peaks in the first 6 months. It wanes dramatically after that. And after month 12, it's virtually non-existent. And, you know, we'll see where that goes. One interesting thing technology-wise, which has mitigated some of the discomfort of the hematologic monitoring, is that there's a point-of-care device. And this is a fingerstick device, which gives you the neutrophil count and other aspects of the CBC by a company named Adherence. I don't own stock in them, but the people who have this device in their offices, and it's now available for home use as well.
You're kidding.
That the patients really like it. Yeah, it's called Adherence Home. They changed the name when they got FDA approval for home use. It really makes life easier for people. Imagine you have a bunch of Clozapine-treated patients in a large group home or boarding care. They just line them up, bing, do a bunch of finger sticks. It goes to the website. The provider sees it. The pharmacy sees it. It is the future.
How does it work with home care? So it's a finger stick, and then I'm assuming you put your finger on a blotting pad of some kind or other.
It's a finger stick like other finger sticks. So you actually have a little strip where you smear the blood on, then it goes into the device, which actually reads it. And the algorithm is in the cloud. So the device is connected to the internet, and the algorithm interprets and does the ANC and the other CBC parameters, and then takes that result and spits it to the provider's interface and to the pharmacy interface at the same time.
I see. So you don't have to mail this or transport this strip anywhere. You just put it in the device and it does it all right there. That's amazing.
Within 6 minutes, you have an ANC result. It's really wonderful. But there are other burdens as well. And that's, you know, part and parcel of knowing how to prescribe Clozapine. And really was the impetus for me putting together the book was the experience I had in trying to educate clinicians at the state hospital in California. Eventually they said, well, these lectures are great, but when you're not there, where can I go to find all this information? And I told Steve, you know, there is no source, and I think I should put it together. And he, you know, really supported me in putting the handbook together.
Yeah, it's tremendous. Let me ask you guys a question. At what point should I think of using Clozapine? How many drugs should I try? How many different classes of antipsychotics? Where should it fit in our algorithm?
Well, the hardy line for people who have written consensus papers on treatment-resistant schizophrenia, and there was a group called the TRIP group, which came up with a protocol, we'd say a minimum of 2. And I think the idea is you also want to verify that they actually took the drug. And I would say, just as a clinician, it would be nice that if one of those drugs, which was a full antagonist, which what I mean is was not a partial agonist. So if one was, that's fine, but one of them should be an antagonist. And that antagonist should not be a really weak antagonist like quetiapine. You know, give them a shot at risperidone or maybe even a slightly better olanzapine and verify that they took it. And at that point, we would say you've earned your right to take Clozapine, assuming you have a diagnosis which is appropriate, which these days would be treatment-resistant schizophrenia, schizophrenia with suicidality. And some of the common uses which aren't on label would be schizophrenia with persistent aggression, impulsive aggression, schizophrenia patients with psychogenic polydipsia. And that's kind of the core uses of Clozapine these days.
Yeah. Yeah, Steve and I did a podcast recently with one of your colleagues in California, and we talked quite a bit about the aggression and how to manage it and where Clozapine fits in. What about LAIs? Where do LAIs fit in? I mean, should we always try an LAI before we go to Clozapine?
Is an important consideration, particularly where adherence has been the issue. For some reason, I don't understand the pharmacology of this, Steve. Maybe you can explain it. When the pill sits in the bottle, that plastic inhibits the action at the receptor side. Well, why is that, Steve?
Yeah, I know Steve's working on a pill that works when it sits on the bottle at the nightstand. I think he's going to make a fortune with that one.
You know, I get so mad at these drug companies. I told them, I said, you make these drugs that don't work unless you take them. I want you to make a drug that works if you don't take it.
Exactly. So a big part of really being a modern psychiatrist is figuring out when people aren't getting better. Is it a adherence failure? Is it a kinetic failure? Or is it a pharmacodynamic failure? Meaning D2 modulation ain't going to solve their problems and they need the magic of clozapine. If they really are non-adherent, then you have to give them a trial of an LAI. Simply to say, look, I gave them D2 blockade. I gave it to them in a way that I could measure the exposure. And at that point, they've earned their right to maybe go on to clozapine.
Speaking of adherence, is clozapine still indicated as a BID drug?
Well, the package insert was created a third of a century ago, and many of the core language never changes, as many of you know. It's unfortunate to say that. A good example is lithium. We now know nowadays that lithium should only be prescribed at bedtime. Because if you give it multiple times per day, over many years, people get more long-term renal dysfunction. It's been well established. That really is the standard of care. If you have to split it up, you give the smallest dose in the morning. But you go to the old package insert, and lithium was approved in April 1970. It still says give it 2 or 3 times a day. So yes, the clozapine package inserts gives it twice a day, but the predominant use in North America is QHS only. At some point, you may exceed their tolerability when you give it all QHS. You get to a point where they say, well, I'm too orthostatic at night. And they say, fine, we'll start adding some in the morning, but there's no reason to give it BID.
Yeah, there's many examples of that. We all know when risperidone first came out, quetiapine, we were giving them 2 and 3 times a day. And really, we're talking about plasma levels and plasma half-lives, and that's not the same thing as how long is it in the brain and bound to the receptors of the brain, which is usually longer.
Well, not only that, Andy, but I've often used the analogy of hugging somebody all day long versus ringing a bell. Now, if your receptor has to be on the drug has to be on the receptor all the time, and that's actually true for some drugs like ADHD. If your stimulant isn't on the norepinephrine transporter, is to a certain degree, once it is below that threshold, it stops working. So you got to hug the receptor all the time, and then you want to be off of it so you can sleep at night. That's not true with most antipsychotics. It's more like having a hammer and a bell, and you hit it and you ring it. And that hammer is only touching the bell for a short period of time, but the resonance of the ring goes on and on. So the nature of blocking D2 receptors doesn't necessarily mean you have to occupy them morning, noon, and night all the way around the clock all the time, and allows you to give shorter acting drugs less than several times a day.
Well, that's actually more physiologic, isn't it? I mean, that's how endogenously neurotransmitters are coming on and off the receptors all the time anyway, right?
Right. So nobody's, basically drunk with the dopamine in your synapse all day long. So, these ideas that you have to have plasma drug levels all the time are not necessarily the case for all drugs in all patients.
Yeah, of course. Well, Jonathan and I have had moments when we have striven for being drunken on dopamine. I'll admit that. But
I've seen you both in that kind of condition, by the way. We'll attest to that.
Yeah, not always pretty, but still interesting. Okay, let's talk a little bit about, let's say hopefully we've convinced our audience that they really need to consider clozapine and incorporate it into their practices and their algorithm. So, Jonathan, what are some principles about how to initiate clozapine?
So a couple of core principles revolve around trying to minimize drug-drug interactions. So first of all, if you can, try to get rid of things which have significant kinetic interactions. I mean, the biggest offenders are the strong 1A2 inhibitors like fluvoxamine or ciprofloxacin. Most people aren't on a lifetime Cipro, so that's usually not an issue. But if you have somebody on fluvoxamine, it's probably better to switch them to an SSRI with minimal interactions like sertraline. Of course, if they're on inducers, that also presents a problem. Omeprazole is a notorious inducer, and it lowers clozapine levels substantially, as do certain anticonvulsants like carbamazepine or phenytoin. So again, try to get rid of those and find alternatives. There's nothing special about omeprazole. You can put them on lansoprazole. The other thing is trying to minimize pharmacodynamic interactions. And the biggest thing is anticholinergic burden. So what are the sources of anticholinergic burden? One of which could be the antipsychotic itself. Well, you can't stop that when you start clozapine, but you can cross-taper it as you add the clozapine. But certainly if you have people on anti-Parkinsonian medications, clozapine will become your anti-Parkinsonian anticholinergic. So for a non-smoker, you can get rid of 1 milligram of benztropine for every 50 milligrams of clozapine that's added. Also, you want to get rid of other things that make people really constipated, like iron. And one other group of medicines that people forget about are the anticholinergic bladder medications like oxybutynin. They also should be removed as clozapine is added. Clozapine will be all the anticholinergic you'll ever want, wherever you want it. And having those medicines on board is going to double the risk for ileus. So that's kind of a basic thing. And then the other thing is just adjusting the titration to the person in front of you. Older people, especially as outpatients where you don't have as much control, it's going to be a slower titration. So you can watch for orthostasis and sedation. If you have somebody with a certain heritage, which might be associated with having a higher frequency of 1A2 poor metabolizer status, and these are people often from East Asia, well, I'm going to go a bit more slowly because I'm suspicious that I may have a higher plasma level for any given dose. If you're on an inpatient unit, you have a vigorous person, you can watch them every day, well, you maybe can titrate a little more quickly. But I think the idea is you don't want to give people significant side effects that you can't manage. And that means you have to go a little bit more slowly. That's fine. Because if the person says, I don't want to take this stuff, what else do you have to offer them?
Yeah, that's certainly true. That's a question I know you and I get asked all the time. What happens if they fail clozapine? And that's another question I'd like to get to in a minute. But hopefully, again, we've got people interested here. Why is it important? You've started talking a little bit about the metabolism. Why is it important for clinicians to understand a little more about the mechanism and how much do we know about the mechanism, of course, and the metabolic pathways and the kinetic properties of clozapine?
Well, the mechanism of action is a bit of a mystery. And maybe I'll ask Dr. Stahl. So here's the hypotheses I often talk about. There's probably glutamate modulation. There's probably muscarinic agonism and maybe some TAR1 agonism. Have I forgotten anything, Steve?
Well, I think those are the best idea, but one of the things that you said by not saying it is it's not D2 antagonism. So mostly, Jonathan has put this forward in the way he profiles these meds for people in the state hospitals. If you want a non-D2 mechanism, then this is it. How it works is mysterious, and he's given you the candidates. And this is sometimes why we combine, maybe we'll talk about it a little bit later, D2 antagonists with clozapine, because clozapine is working by this somewhat mysterious way, but not D2.
5-HT2A antagonism we thought was part of the story as well, I guess. But really, it could be that the whole's greater than the sum of the parts. It could be all of the above.
Yeah, clearly. And I didn't mention serotonin 2A. We think it does help. It certainly helps when you have very low levels of D2 antagonism, with the extreme example being a medicine called pimavanserin, which is only indicated for Parkinson's disease psychosis. It has no D2 binding. It's all serotonin 2A and some serotonin 2C. And it does have antipsychotic properties. So you're right. It does help it along. And I think clozapine clearly is the sum of the parts. It's not one particular individual mechanism. But to be honest, you could prescribe clozapine and not really understand how it works because, to be honest, nobody really understands. It's more important to understand how it gets metabolized and some of the potential for drug interactions and some of its pharmacodynamic properties, especially the anticholinergic issue in the GI tract. It's a little bit of a mixed bag. You get sialorrhea from cholinergic agonism, which is probably from the metabolite. But you get constipated from the anticholinergic properties, and that's really important because we don't want to combine clozapine with other strong anticholinergic medications, or if you can avoid it, even with iron.
Let me elaborate on that a little bit, Jonathan, because this might be confusing for our audience. So what you're saying is clozapine has both muscarinic agonism, presumably M4, and some degree of maybe M1 or other muscarinic antagonism. Is that right? It has both properties?
It actually has M1 and M4 agonism, so that's why it probably has some antipsychotic properties from the M4 and M1 centrally, but peripherally in your salivary gland, you see the effects of M1.
That's M1.
But in the gut, you're seeing antagonism as the predominant property.
I see, and the other muscarinic receptors.
So this is going to be confusing pharmacology, but it's probably good for the listeners to start getting used to it. We are talking about a revolution, really, in the psychosis, which maybe was started by clozapine, by giving agonists, not antagonists, for muscarinic receptors. Now, it's confusing because there's 5 muscarinic receptors, and in the case of clozapine, it has both agonism and antagonism, and it's different inside the brain versus outside of the brain. But you can handle it, listeners. It's not that hard. But if you want to understand the new Karuna drug, which is, going in probably the FDA for approval, possibly within a year, it works by M1, M4 agonism, maybe stealing a chapter out of the book written by clozapine.
Exactly. And, we've known for years that clozapine is not only a very effective antipsychotic, but may have procognitive qualities. And we think M1 agonism could be part of that story as well. So it's fascinating that as we started out this podcast, we talked about how people are afraid of this medicine. And one of the reasons they're afraid, frankly, is the anticholinergic effects. And as Jonathan, you said, the ileus. But I think that there's more to this story here. And it really is interesting to understand the pharmacology. Jonathan, what about anti-alpha properties? Do we have to worry about orthostasis or anything else with the alpha receptors?
We do. Clozapine has a range of adverse effects, which we saw in certain low-potency older antipsychotics like chlorpromazine. So you get some anticholinergic stuff in the gut, for example. You get sedation, do get orthostasis, but also there is a tachycardia independent of the orthostasis, and that's another part of recognizing when you're treating clozapine-treated patients. If they're tachycardic, well, first you make sure they're not orthostatic. If they are, you treat that, but they can be tachycardic without orthostasis, and that's also probably a muscarinic agonism property.
I was just going to ask that, yes.
One of those things that you see with clozapine, again, not the most difficult thing to treat. If the person's not orthostatic, we use atenolol as our beta blocker of choice.
Sure. Well, that certainly makes sense. Well, let's talk a little bit about managing some of these side effects. Let's start with sialorrhea. What can be done with sialorrhea?
The principle of sialorrhea is we want to avoid systemic anticholinergics until we get to the end of the algorithm, because those are going to double our risk for ileus. If we ever use a systemic anticholinergic, if you get to that point, the drug that we will pull usually from the pharmacopoeia is glycopyrrolate, because it doesn't cross a blood-brain barrier. We do not use diphenhydramine. We do not use benztropine for sialorrhea ever. But before you get to that point, our preferred agents are locally acting anticholinergics like atropine drops sublingually under the tongue, or ipratropium spray, which was marketed as a nasal spray, but we sprayed in the mouth, and the higher strength of 0.06% is what we use. Minimal systemic absorption, and they often will dry people up enough that it solves the problem. The most important thing is drying them up at night. Clozapine can cause a couple of types of medical hospitalizations. Let me tell you, neutropenia is not the problem here. It's aspiration from untreated sialorrhea or ileus. So dry people up at night. It's really important. When I trained, I was taught, put a towel on the pillow. And nowadays, when people suggest that this is what they learn, I say, well, good for the pillow, but that doesn't help your patient at all.
Exactly.
What about that trick up your sleeve that we're doing at Patton and other places for sialorrhea that doesn't respond to what you've been talking about, Jonathan?
Yeah, so next on the algorithm, before we get to glycopyrrolate, is actually botulinum toxin injections into the salivary gland.
Sure.
I need that for my face. I don't know.
That's actually FDA approved. There is a product that's on the market. It's FDA approved. Myoblock, I believe. Is that right?
Yeah. Two of the agents actually have approvals for sialorrhea. So this is not some weird thing which I invented all by myself in some corner of the state hospital. These drugs are indicated. You can think of Botox. If you never knew the mechanism of action, they are permanent anticholinergics. They disable the mechanism of cholinergic neurotransmission. They actually really disable the protein, the snare protein, which causes the vesicle to fuse with the plasma membrane. And these are our next step if people fail the locally acting agents. We use the maximum allowable dosages of the toxin, whichever one you use, A or B. It does take a bit of time. Unlike, let's say, a cerebral palsy patient or Parkinson's disease patient who might drool, our patients have a chemical stimulus for drooling. And so it takes time for the toxin to get in enough and disable enough the cholinergic machinery to overcome the constant stimulation from norclozapine. But it works beautifully. You just have to give it some time. It may even take a couple of rounds of injection, so one every 12 weeks. But if you can avoid going to a systemic anticholinergic like glycopyrrolate, you've done your patient a huge favor.
Yeah, I was trained to use glycopyrrolate, so I'm glad to hear there's other options. And, ipratropium is ringing a bell. I believe when I did my internal medicine training, we used to use that for asthma, if I'm not mistaken.
Yeah, there's a nasal form, there's an inhaled form. Yeah. Don't spray it in the patient's nose, spray it in their mouth.
Yeah, very helpful. All right, let's get to the other really, really concerning one, and that's the ileus. Is there anything that can be done to minimize or prevent that, or how do you deal with that, or to assess for it?
It's a pretty straightforward protocol. The one thing I'll say, which is probably novel to certain people, is we don't use psyllium. If you and I are constipated, we go to the store, we buy Metamucil, which is psyllium. Psyllium is really good if you're a little constipated, meaning your motility is maybe double normal, which would be maybe 48 hours. That's fine. But people on clozapine, their colonic transit time is often greater than 100 hours. And psyllium will just sit there and it'll dry out and become a gel in the colon and make the problem worse. So number one, never give these people psyllium ever. Number two, everyone gets started on Docosate. It's like a party favor. Oh, you're on clozapine. Congratulations. Here's your Docosate and your bag of goodies. Everyone gets Docosate from day one. And then you just add sequentially other agents. So we'll add an osmotic second if the Docosate's not enough, and that's usually Miralax or polyethylene glycol with a generic term. If that's not sufficient, then we will add a stimulant. And the stimulant we prefer is bisacodyl. Doesn't matter. You can use Senna. I don't care. Max that out. If those are not enough, which is often the case, then we go to what are called the secretagogues. And these are these new medications which directly cause secretions into the colon, which relieve constipation. You may have seen ads on TV for a medicine called Linzess, which is linaclotide. That seems to be our preferred secretagogue at the state hospital. It often works so well, we can get rid of many of the other medicines. And we've even had people who developed ileus who weren't given the secretagogue. We put them back on clozapine. We give them the secretagogue, and it allows them to stay on it. So do not stop short of going to the secretagogue. It is your best friend, and you should use it. And the only thing I just want to say is also make sure you've gotten rid of all the other systemic anticholinergics, and if need be, iron as well, temporarily until you get the problem under control.
This is such a good point because I think there are a lot of medicines that people don't realize have anticholinergic effects, and our patients end up on multiple medications to manage all kinds of things, medical problems and the like. And, even if a medicine has a little bit of anticholinergic effect, it adds up if you have multiple medications. So I think it really is a good idea to look at the big picture and really evaluate, does this patient really need this medicine?
Yeah, absolutely. Especially the overactive bladder medicines. They're anticholinergic. Well, I'm going to give them an anticholinergic, so we don't need both. If they're on benztropine, which we were trying to get rid of in medicine in general, but if you had people on it, fine, the clozapine will become your benztropine. And as I said, the ratio, if you're a non-smoker, is 1 milligram of benztropine is 50 of clozapine. If the person's a cigarette smoker, they're burning the leaf, not vaping, then the ratio is 1 milligram of benztropine for 100 of clozapine. But essentially, the clozapine will now become your anticholinergic, anti-Parkinsonian for that patient.
Yeah, that's that's really important. And also, a lot of people with tardive dyskinesia end up on clozapine. That's something we used to do back in the day. And there are still people, Jonathan, I realize I'm touching on something that you and I are passionate about, but there's still people giving Cogentin or benztropine, I should say, for TD. And so now if somebody comes to clozapine and they're on benztropine, that is bad news.
Oh, yeah. There's not too many ways you can do somebody in the world of psychiatry, but having somebody on clozapine with multiple strong anticholinergics on top of it really can be a fatal combination. And that's just something to be avoided. Again, if somebody comes in on benztropine, that's fine. You'll just cross taper it off as you add the clozapine, but you got to make sure you get rid of it.
Keeping up with the latest in psychiatry shouldn't be a struggle. SynovianFieldMedical.com is a new website for clinicians where you can find a library of free hand-selected resources, such as videos and infographics on important psychiatry topics. You can request an educational program for your practice or connect with Synovian medical professionals in your area. Synovian wants to help you get all of your psychiatry questions answered. Go to synovianfieldmedical.com and explore what Synovian has to offer.
All right, let's talk about another issue with clozapine, and that's the weight gain and metabolic effects. What's the latest thinking on how to manage that?
Well, I think we should recognize that people will gain weight on clozapine. They will get metabolic effects, and especially if your heritage is non-white, it's going to be even worse for a variety of reasons. I think in this day and age, we would say everyone starting on clozapine really should be given metformin. Metformin works best to mitigate weight gain when you started at day one, not when they've already gained 25 pounds. The only, I would say, clinical pointer on using metformin is go slowly at first. I used to endorse maybe titrating it by 500 milligrams a week, but the endocrinologists have gently counseled me and say, maybe keep that 500 for 3 weeks so you don't give people GI adverse effects, and then you can go up from there.
Exactly.
But it does help, but it works best from day one.
Yeah, so the dosing ultimately is the same as it would be for diabetes, and there's really very little hypoglycemia caused by metformin, so you're okay doing that. So ultimately, your target is a gram BID, but there's no hurry to get there, as you're saying.
Yeah, at least for the first few weeks. And then you can move up pretty quickly. Most people will end up on 1,500 to 2,000. And there are extended release preparations. If you start to run into GI issues, then you could just switch them to one of those. I'll say
and the GI
nowadays, nowadays, if you have people who have become obese on clozapine, we now have 2 FDA-approved GLP-1 agonist medications, which are indicated in non-diabetics for just weight loss. And those now will be your go-to medications if people gain enough weight that they meet criteria for obesity, or if they're overweight, but they have an obesity-related complication such as hypertension, dyslipidemia, or diabetes. So I'll give you the generic names of these. One's called liraglutide, and the other is semaglutide. And they each have 2 forms. One's indicated for diabetes. One's indicated for weight management in non-diabetics. And that's the one you want. Tremendously effective. I mean, people may lose sometimes 12, 13, 14% of their body weight on these agents.
Yes.
They're expensive, but most Medicaid systems will cover them.
Yeah, no, I absolutely 100% agree. And so many of our patients develop insulin resistance, and if not frank diabetes, that it certainly makes sense to use these drugs. These drugs have revolutionized the treatment of diabetes, and the weight loss has been quite impressive. There's even a newer one that is a combination drug. I'm blanking on the generic name, but it's both a GLP-1 and a GIP agonist, I believe.
That's right. I think right now it's only indicated for diabetes, though, so we'll have to wait to see if they get the weight loss indication independent of diabetes.
Yeah, but so many of our patients do end up with diabetes anyway. So I think you're right. The GLP-1s really need to be now considered in our algorithm. And there's abundant evidence, believe it or not now, that GLP-1 agonists may be very beneficial for the brain. They may be neuroprotective. They may really improve insulin metabolism and management in the brain. They are maybe pro-cognitive, neuroprotective, as I said. They're being studied for diabetes, for mood disorders. So really interesting, this idea of repurposing our drugs here. And then, of course, tried and true old-fashioned things, preaching exercise, diet and exercise. I've definitely had patients who can modify their lifestyle, especially when they're on clozapine and they start getting better from the psychosis.
Yeah, no, I agree. And I thank you for bringing that up. Really, everyone should be given lifestyle, education, nutritional counseling when they're ready for it. Especially as people improve, they may be able to act on the information. But if you never give it to them, they're unlikely to do anything. As I always joke, Steve, I think exercise is a great drug. I can't get anyone to take it. But when they do, it makes everything better, right?
It supposedly causes neurogenesis and, more synapses forming and so forth. It's more so than mental exercise. Physical exercise is good for your brain.
Yeah, reduces systemic inflammation. And we know that's the enemy of the brain, right, Steve?
That's right. That's right. Yeah, Steve, we need to, besides patenting a medicine that works when you don't take it, we need to patent exercise. It's a pretty darn effective treatment.
lets you, all three of us do that, we make a lot of money patenting exercise.
Yeah, we could.
Mm-hmm.
But
there are side effects, unfortunately.
There are some side effects.
I will say this though: when you look at meta-analyses of exercise and schizophrenia, yes, it improves metabolic parameters, but it also improves every symptom domain, and
Really?
It's one thing that really makes people feel better overall. So it's not just a physical thing. The mind, body, they're all hooked up, and when you get people to exercise, maybe it's because it's reducing systemic inflammation. Who knows? But it improves positive symptoms, negative symptoms, everything.
What improves the body's ability to extract oxygen and nutrients from the blood, and it improves blood flow throughout the body. So, I mean, there's so many things that it's probably doing. And then there's potentially weight loss as well, which is what we're shooting for here. Okay, Let me shift gears. You talked a little bit about the point of care blood monitoring for the CBC, the neutrophil count. Let's talk a little bit about plasma level monitoring. And I know you have another handbook that you and Steve have written on that topic, and we'll be talking about that in a subsequent episode. But let's talk a little bit about that, about plasma monitoring. And first of all, can you monitor the plasma through this point of care finger stick thing you've talked about?
Yeah, so the one device I mentioned just does blood count. That's a single purpose device. But there's another company which is working on a point-of-care device to track antipsychotic plasma levels, and clozapine will be one of the analytes. As of now, that is not yet FDA approved. They're still gathering the data for their FDA submission. But the assay they developed for that is an immunoassay. And what's the beauty of that is that it can be added to any standard laboratory analyzer. And clinics and hospital systems which have gotten this assay now can turn around their clozapine levels within hours, just like a lithium or a valproate level. It's really transformed their whole care model, because now you can use it to see how people are metabolizing clozapines. You can optimize efficacy. If they have tolerability issues, you can look at that. And then periodically, once people are on stable doses, we can check their levels just to see if they're taking it or if anything has changed in their clozapine metabolism. For example, they started smoking cigarettes again. That's available now, and maybe the finger stick device in the future. But I think the point is that if anyone knows anything about plasma antipsychotic levels, they know about it with use of clozapine. And like most antipsychotics, it doesn't work well below a certain threshold level, roughly below 350 nanogram per ml. And you know, when people aren't getting better, our initial response in the state hospital is if the level's below 350, let's get it above 350 because you're not yet in the ball game. And then at that point, you'll continue to titrate it until they do get better or until they can't tolerate it anymore. But the idea is we don't have much else to offer them, so let's just keep pushing it along as much as we can. And we'll go up as high as 1,000 nanogram per ml in search of efficacy in someone who's a non-responder.
So it is very important to measure plasma levels with clozapine before you give up on it, it sounds like.
And I think early on, too, you know, there's population differences in drug metabolism. As I said, by heritage, you might suspect somebody might be a poor metabolizer at 1A2 or 2D6. It doesn't matter. Rather than guessing about their heritage genetically or spending your money on a P450 test, just measure the levels. And early on in the titration, that can help you figure out what's going on. I said in the Clozapine Handbook, maybe get a level when they get to 200 QHS. It's a nice round number. If you have somebody who you think may be more sensitive or metabolizes the drug more slowly, fine, get it when they're at 100 QHS. But it gives you a lot of information there. And it also tells you how far away am I from the initial target of 350? I mean, if they respond at 350, who knows? That's between their brain and the deity upstairs, but at least it tells you how much will I need to give them to at least get to that initial target.
So let's quickly review the metabolism. You mentioned 2D6 and 1A2. I suppose those are the predominant enzymes that metabolize clozapine. Are there others we need to be aware of?
Yeah, and 1A2 is number one by far and away. So it's mostly through 1A2, and that's why if you give a medicine like fluvoxamine or ciprofloxacin to somebody who's already on clozapine, you could actually do them in. And Steve and I wrote up a case that he consulted on, which was a legal case, right, Steve, where somebody was given ciprofloxacin, and the outcome wasn't good, was it?
No, goodness.
Patient died.
Yeah, patient died. So now the 2D6 effects are much more modest. If you gave somebody fluoxetine or bupropion or paroxetine, at most maybe you'll double the level. So not quite as serious. So 1A2 is the big one. And that's why also the cigarette smoking thing becomes an issue. And the only thing I'll say there is that... Yeah, go ahead.
I wanted to come back to that. What does cigarette smoking do to 1A2?
So the important distinction is you have to be smoking cigarettes, not vaping. You have to be burning the leaf, because when you burn the tobacco leaf, or I guess cannabis leaf, doesn't matter what you're burning, you generate aryl hydrocarbons from that burnt organic matter. And those aryl hydrocarbons cause you to upregulate your 1A2 activity. And this will drive your clozapine levels down by about 50% compared to a non-smoker. But
so you speed up the metabolism. Yes.
Quite a bit, yeah. But
and you're
vaping,
saying,
I was going to say, if you're just vaping and you're not burning a leaf, you're just inhaling a nicotine vaporized solution, you don't induce anything. So that's the important distinction. If they're a cigarette smoker, they're going to have lower levels compared to a non-smoker. If they're a vapor, it's just like somebody who's a non-smoker because they're not burning the leaf to induce their 1A2.
Right. And so it's not the nicotine. That's important to realize as well. So if somebody's using chew or dip, that's not going to do it.
Right. Exactly.
Now you're saying also smoking marijuana does this too?
As long as they're burning a leaf. You just have to ask them. If they say, I smoke whatever it is, weed, cannabis, tobacco, how are you smoking it? They say, I have a vape pen. Fine. They're not burning a leaf.
Yeah.
Now, of course, when people smoke cannabis leaf, they're not quite smoking the volume of cigarettes. And so the effect may be somewhat unpredictable. But I think the idea is, just measure the level, and that tells you the answer. And that's really gets down to the basic principle. Don't guess, measure.
Right. I like that. Marijuana is fascinating. It has several pharmacokinetic effects. We talked about inducing 1A2. It can also inhibit 3A4, and it also may have some actions at some of the other cytochrome P450 enzymes. And a lot of people are smoking marijuana now. So we need to be really careful monitoring our medications, I believe.
Yeah, it also doesn't make schizophrenia better. I'm not sure why that is, Dr. Stahl.
No,
I think that is. Cannabis doesn't make your psychosis better.
Well, it's one of the great quandaries because if you are into the dopamine hypothesis, you'd think the worst drug for patients with schizophrenia would be a stimulant, cocaine or methamphetamine. And although they don't do you any good, it turns out that marijuana is the worst. And in fact, it induces the onset of schizophrenia like no other drug does in patients who are vulnerable.
Yeah, I don't know if you guys realize, over 20 years ago, I studied a drug, rimonabant, that was a cannabinoid receptor antagonist for schizophrenia. The theory being, of course, if you stimulate cannabinoid receptors, you can precipitate psychosis. And it wasn't as effective overall, but it was an interesting theory. So, yeah. Okay, let's shift gears. You mentioned, Jonathan, a legal case that you and Steve consulted on. I want to ask a funny question here. Is there a legal ramification now for not prescribing clozapine?
Yes, there is, because you're not providing the standard of care. If you have somebody with treatment-resistant schizophrenia, we now know from the evidence is nothing else is going to work. The chances of anything responding are less than 5%, and for olanzapine, maybe 7 to 9%. For clozapine, it's 40% plus. So number one, you're depriving people of the standard of care. And certainly if you're trying drugs where there's no evidence for efficacy, treatment-resistant schizophrenia, so let's try the newest one. Well, that also will be below the standard of care because you're really experimenting on your patient with no evidence to suggest that this drug might be effective. And the saddest part is that there are many systems, both forensic and non-forensic, where they systematically refuse to prescribe clozapine, and they're actually going to be the subject of litigations. I had a case where I was consulted by a family. Their loved one was in a community hospital in El Paso. I won't say which one. And the provider literally said I don't want to start them on clozapine because I'm worried about my liability. And they're thinking, if they have neutropenia, I'll be liable. Well, it's the exact opposite. They're going to be sued for depriving them the standard of care. And it's going to be successful.
Not to mention, that there's a high suicide rate in patients with schizophrenia in general and treatment resistance in particular. And if you don't use clozapine, which has evidence that it mitigates that, you're below the standard of care. You could possibly avoid saving someone's life by avoiding clozapine.
Well, and certainly we know there are patients with recurrent aggression and violence, and God forbid someone commits a homicide and they could have been treated with clozapine. I could imagine that also.
Yeah, I think the idea is it's not that difficult to prescribe clozapine. There's a few things you need to learn. If you really feel like it's beyond your abilities, which I don't think is true for any of our listeners, but if you really think like it's beyond your abilities, then you are obligated to find that person a provider immediately, as soon as you identify they're treatment resistant, to get them on clozapine, partly for your own liability, because you're not providing them the standard of care. Also, as Dr. Stahl said, so maybe we can prevent them from committing suicide, for which you will also be liable. But third, because, you want to make sure that this person is starting on clozapine earlier on their illness, because we have evidence that if you start clozapine within a shorter time of becoming treatment resistant, you might get a bit better response. Now, that's not a reason to deprive somebody of clozapine who's been ill for 30 years. We do it all the time in the state hospital. But we feel like, based upon the evidence, that getting people to clozapine sooner, maybe there's more brain to save, perhaps, certainly more symptom improvement. And that's another reason that if, for whatever reason, you feel like it's beyond your abilities, that you have to have a connection where you can get this person on clozapine. The only thing I'll say is if you're working in a system where they say we don't prescribe clozapine, you are now personally liable because you're part and parcel of that same whole system, which is really depriving people of their civil liberties, for one thing. If they're incarcerated, it's really not practicing the standard of care. And I would encourage you, if you're working in those systems, you may want to find another job.
Sure.
No, seriously.
Well, it strikes me.
You'll have no defense. Yeah. You'll have no defense.
Yeah.
If this patient was not given clozapine, because you say, well, in our jail, we don't prescribe it, the patient hangs himself, and your license is on the line right there. I mean, that's it. And
I think it's very well known. Yeah, no, I think it's very well known that clozapine has anti-suicidal properties, and it's indicated for that. So I think you're right. It occurs to me, too, speaking about using clozapine earlier, we also the current thinking is now to implement LAIs perhaps earlier, too. So both of these very effective modalities that are both underutilized really should be considered sooner for the very reasons you're describing.
Absolutely.
Yeah. All right. Well, I wanted to ask another quick question. Not every pharmacy obviously stocks clozapine. So let's say I'm a doc in community practice and I want to start prescribing clozapine. What do I need to do to ensure that the patient can find it and get it?
I think in most big cities, I'll say any city of 250,000 or more, usually has a couple pharmacies that often specialize. These are typically maybe more independent pharmacies run by a family as opposed to the big chains, and they often specialize in dispensing clozapine. They know how to deal with it. So I would ask around if you're new to that city or if you're just getting started because you're new in your career at prescribing clozapine, talk to people like, oh yeah, we all send all our patients to Al's pharmacy because for one thing, they'll maybe send the drug to the patient's house and they work well with us and they know all about the REMS. And I think that's the most important thing. The other thing is if you can get one of these finger stick devices for ANC, people love it because for one thing, they come in, they don't have to go to a separate lab. It doesn't hurt as much as phlebotomy. They get the result right away and they're good to go. And that really diminishes some of the monitoring burden for patients.
Yeah, and as you said, there's just a dashboard then on my laptop, and I've got it documented, and there it is. There's a pharmacy chain. I have no stake in this company either, but I want to mention called Genoa Pharmacy that's now national, and really specializes in psychiatry and CNS medications, and I found that they do an especially good job, and they're often co-located with community mental health centers or other healthcare facilities. So yeah, there definitely are others out there that can do this. Well, Jonathan, we're getting close to the end here. I just wondered if you have any overall advice for clinicians who want to start utilizing clozapine more in their practice. What would your advice be? Any other considerations that they should think about?
I think kind of drawing from your logic of LAIs, one thing you have to offer to people when they're treatment resistant, we say, look, you've now failed 2 drugs and I push that antagonist, olanzapine, up to as much as you can handle, and then you got Parkinsonian. So that's it. You need clozapine. Let them know nothing else is really going to help them. They may say no, but consider it not the no forever, but an ongoing conversation where maybe at some point they'll eventually realize you have their best interest at heart. You really are telling them the truth, and that clozapine is the only thing likely to work. And the most important thing is just don't make it a one-time conversation. It's going to be an ongoing conversation because patients over time will change their mind as they realize the other medicines aren't working. And then use it. It's not that difficult. If you're concerned about managing adverse effects, then titrate it more slowly if you're on an outpatient side. So you can get on top of the salivation and the constipation and the orthostasis and the tachycardia, and get a resource for knowing all the information. I mean, I wrote the book not to make money, but to help clinicians. But there's other resources as well. Just find the information that will help you. It'll demystify some of your concerns. Really, nobody in the United States, and I will say almost nobody in the United States, dies of severe neutropenia from clozapine. That's not the issue. The issue is learning how to manage constipation and salivation and some of the other adverse effects. It's not that difficult, but once you've done it, 5 times, you'll have seen most of the adverse effects that anyone will see. And then you'll realize, hey, this wasn't such a big deal after all.
Jonathan, what is clozapine use like in other parts of the world compared to the U.S.?
Much greater. There actually was a paper looking at international use. There's some countries where it's 10, 20 times. I mean, in the U.S., it's still a fraction.
Wow.
I mean, small fraction. Considering the fact that we would say at least a quarter of schizophrenia patients are treatment resistant, and we're talking 1%, some states less than 1%. It's really a black eye on the mental health profession, but one that I hope I can change by educating folks like you who are listening to this podcast. And hopefully you can take this message forward with the idea of changing the culture where you work so that people will no longer say, oh, I don't prescribe clozapine, and think that's an acceptable statement. I mean, who would go to an oncologist who says, well, we got this one drug that about 40% of people respond to, but I don't prescribe that. And I'm going to give you something which I have no idea if it works or not because it's new. It would never be acceptable. And I think the idea is we want to change the culture to using clozapine, use it early, and use it wisely.
So if I hear you right, step 1 is consider clozapine, add it to your algorithm. Step 2 is to offer it and continue to offer it to your patients. Psychoeducation, start the conversation, and use it. I think those are wise words, Jonathan. By the way, Jonathan, I think you're very modest. I believe you when you say you're just writing this book to improve healthcare, but I think you've done a great service, and I hope that people will get your book, yours and Steve's book, and it's a tremendous resource, and I hope they will use it because it is a modality that can literally save people's lives. Steve? What are your thoughts to clinicians out there who might be considering this? How are we going to get them off the fence?
Well, I think it's up to us to have a vision and to provide leadership and to say that if you want to practice mental health as in this area, you have to be able to prescribe this drug because this is something that is in our bailiwick. We also have to be able to manage side effects, which allows you to actually practice a little medicine as well as psychiatry. So that's psychiatry should be that way. It shouldn't be the easy way out. Prescribe a drug that is easy to give and doesn't need much monitoring because it's easy for me. It's not about us. So the leadership here, and I follow in line, following Jonathan's vision, is to, hey, it ain't that hard. Understand a couple of things about side effects, and you can be a modern mental health professional.
I like that. And Jonathan, I love your analogy of oncology. I think you're right that chemotherapies, some of them have toxicity. Some of them are a little more challenging to administer and to monitor, and yet nobody would give a second thought about that. So I hope we've convinced people. Well, we've reached the end of our time. It's been a pleasure as always. Jonathan, I really want to thank you for your work in this area, for this book. Any final closing words?
Well, I think Dr. Stahl really summed it all. You have to have a vision that if you're working with schizophrenia, this is the standard of care. It isn't that difficult. I think everyone listening here is capable of prescribing clozapine. Don't be fearful. Just learn. And as you learn, you'll understand that, hey, I didn't have as much to be fearful of. Now I understand how to manage this. And you're doing your patients just a great service by providing them really the only drug that in this day and age might really give them the hope of a functional recovery.
Well said. Well, I want to thank you all for listening. Please tune in for the other podcasts in this series, the PsychopharmaStahlogy Show. And NEI, we have a whole number of other podcasts. Some are CME, some are not. So to check out more of our offerings, all of our different educational products and offerings, please check out our website, www.neiglobal.com. That's neiglobal.com. So I want to say goodbye and thanks so much, guys. Jonathan and Steve, thank you both so much.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.